crown, and 20% of the time it's going to fail, are you still going to do the treatment? But we do an implant on a daily basis, and we see real problems. And the challenge is not really how we treat that, it's how we take care of the patients. Patients already spend a lot of money, including a surgery, to go through the implant surgery, implant treatment. And then you tell them, I'm sorry, you have to go through another surgical treatment to treat the periodontitis. Even I myself cannot accept that. So GPT really is a game changer to me, for the management of peri-implant diseases in a way that we can manage a lot of times non-surgically. So take this patient for example. Obviously, you can see a bone loss around implants 4, 6, and 4, 7, with some deeper probings. And so here's a video. Okay, so we just close. This is a non-surgical treatment. We just close and supragingival airflow. And we remove the crowns, we retain crowns, make the emergence profile more cleansable, easy to ID cleaning, and then we probe again. And then subgingival airflow. And here, this is before Xiaosu came to Hong Kong, so this is not the right way of doing this. For educational purpose, I'm showing you how I did it not correctly.
I would not say this is incorrect, because if you have the space around the implants, you could move it horizontal. No, this is the only way, otherwise.
But we took that under the microscope, and this is the previous peak. I don't like that. You can see calculus here under the microscope, but it was not efficient to remove the calculus. That's why so we're going to change that. I'm glad we changed to PI max, and then we put in local application of minocycline. So before the age of PI max, I don't like the peak, the white ones. I still use PS tip around the implants. You can argue I'm going to roughen the implant surface. Come on, there's calculus. I don't care.
It's already
it's already there. It's a rough surface, so it doesn't matter.
So it's good you have the PI max approach.
Even if you use the PS around the screw head, it doesn't matter. It's just the polished part which you have.
Please.
Jack, did you give local anesthetic or no local anesthetic?
Excuse me?
Did you give the patient local anesthetic?
Oh, yes.
And which local drug delivered? Which
minocycline. This is minocycline.
But what is the brand that you use?
It's Sunstar. It's from Sunstar, the Japanese one. I will look into that. Minocycline. Okay. It's a local application. Well, there are different recipes. There's no standard protocol of treating periodontitis. Trial and error. Trial. Okay.
No error.
Yeah. But at least what's the other route? Explant, do vertical bone grafting, spend another 2 years. Who's going to pay for that? Okay. But we received this kind of situation. So I do think non-surgical periodontal treatment for the implant is a good solution. This is 6 months post-op. Obviously you can see the recession around both implants. Good. It's posterior. We don't have to do additional work. And once again, periodontitis is a lot of contributing factors, including emergence profile, the accessibility that we can use for incidental cleaning. And I updated this because I want to have a 1 year post-op. And also, seeing is believing. I also recall 6 months I did the probing. Sorry, you can criticize whether I do the probing right or wrong. Well, at least I want to show you the pocket is reduced, and the inflammation is also greatly controlled, I would say.
Yeah, the soft tissue looks great.
Yeah. It's 6 months.
How often do you put the patients? Every 3 months,
Every 3
at least, yeah.
Yes.
So like in Japan, they do have a contract that they sign, the patients. I don't know if it's done in other countries. When you have an implant placed, if you don't come every 3 months for a cleaning, we're not responsible. So it's automatic GBT, done.
Right.
You have the same, more or less similar protocol.
We encourage patients. We have warranty program, but they have to follow certain criteria, quit smoking, and at least once every 6 months.
I do that for bonding cases. I say if it looks rubbish and the key doesn't keep the luster, and you're not coming every 3 months, then you have to pay to get them. Yeah.
But I'm here not to show you the good result. I'm here to show you not ideal ones. So that's why I updated the photos thing. You see these implants, they are moderately roughened surface. No matter how optimal your oral hygiene is, they still tend to trap bacteria really readily. And let's take a look on 1 year post-op. Clinically, it doesn't look too bad. Okay, I didn't even bother to put in my period charting because this is the best chart you can see, right? I probe quite hard, you see,
I can
it's
see
flinching.
that.
So I need to
Really
show you this
trying.
one pocket. I just know this may not be the ideal with T-probe. But once again, you see, I wish it could be a huge screen. There's still a lot of bacteria, biofilm around this because it's just rough on the surface. No one's gonna clean. Of course, for periodontists, we can do implantoplasty, smoothing everything, make it a polished surface. But I didn't do the surgery once again, so I think that's.
And what do you recommend? How does the patient keep it clean?
So still with the
Home care?
regular home care with interdental brush.
Okay, just interdental. Normal interdental or anything specific?
Oh, the ID brushes, interdental brushes.
The one with the wire. With the wire or just plastic-based interdental brush? With the wire. Okay.
Okay. Yes. So.
Do you,
Okay.
So do you recommend them also to use the chlorhexidine in the?
Yes, there's a hexane gel.
Yeah.
Yes, that can be used in addition to.
And a single tufted is really good to
And tough as well, yes, for these lingual undercuts.
Yeah.
But I want to show you that, me doing the GBT, I try my best, it's four-handed dentistry, but there's still a lot of missing spots for me. So this is, we just close, okay, and this is after. You can still see, especially I take my photos and then we'll show you, my nurse sent me, no, should I show this? I want to show you just for educational purpose. The challenging part is the distal buccal, distal palatal, distal lingual aspects. See here, I didn't clean them. And that's post. And also lingual, it's very difficult to clean in these groups. These are the real challenges, to me at least. I'm sure you can do a better job. You may do more GBT than I do, although me being a periodontist. But once again, this is the real challenge, and difficulty is if you're doing two-handed dentistry, you need to hold the mirror and then see the discipline. This is difficult. I'm eager to learn from you and in the afternoon to see how we can overcome these difficulties.
What I found with the lingual is if you are angling it down into the sulcus,
Yes.
the water builds up and actually the water stops the airflow, removing the biofilm. So you've really got to retract the tongue and go up and then down and do short bursts because otherwise you don't remove the biofilm.
Wow. How many hands do you have?
How many what? I'm four-handed. No, I'm four-handed, but the nurse is
Right.
suctioning from the buccal side.
Yes.
I'm moving the tongue and I'm angling it up and then suction, angling it up, suction. Because if you just try and continuously do it, it will hit the water
Yes.
and it will just be won't work.
So this is the
We
real
still
clinical
recommend
challenge.
two-handed. Yeah, absolutely.
So let's see how we
Is
can
there
do
anybody
two-handed.
here doing two-handed?
Yes.
Yeah. Okay.
Yes. And you can still see the lots of
We still
area
see
of-
it, even when we do two, when we go back with the mirror, when we do the check and we go back again.
Yeah.
So,
So this is the non-ideal situation, but this is what
this is
I
something every division has. I'm sure you all agree. No matter how well we go slowly, we still leave those areas. So it's okay.
It's good that we
We
just
come back.
go to make ourselves better, push ourselves better. I think that's it.